Hello everyone, welcome to the next of the working group webinars for the Trial Conduct Working Group. It's Claire Snowden here, I'm one of the chairs of the group. And after our last very successful webinar with Francesca Sciavioni, we have the follow-up second webinar today, which Lindsey is going to present. And if you were here last time, it was a very nice, lively discussion after Francesca's talk. So hopefully it will be the same today. So as I said, the two talks are connected. Lindsey's going to talk to us about a data management perspective on operational aspects of adaptive platform protocols. And clearly there's a lot of interest in that. Just before she starts, I'll give you a little bit of background to Lindsey's work. She joined the MRC Clinical Trials Unit, the unit at UCL, 10 years ago and has worked in various data management focused roles at the unit in those 10 years. This has led to her current role as a data scientist in the data management systems team. That role involves working with studies in setup and during recruitment to make sure that the CRF systems and processes are fit for purpose, as well as helping to develop the unit-wide data management strategy that she's involved with and training data management staff in principles of GCP. So Lindsey's been involved in developing data management processes and systems for adaptive platform protocols for the majority of the time in the unit. And it's this experience that she'll be drawing on and telling you about today. So Lindsey, over to you. It'll be really interesting to hear what you have to say.
Great, thank you. Thank you. Okay, so as Claire said, I'm going to be talking about, I'll just move to my first slide. So my talk is called Changing Platforms Without Stopping the Train, and it's going to be a data management perspective on the operational aspects of adaptive platform protocols. So adaptive platform protocols, Fran talked a bit about them on her talk if you listened in on that last week, a couple of weeks ago. But they're also known as master protocols or living protocols. And they encompass, so they are protocols which involve several different arms or comparisons, which could then have some of these added or dropped throughout the protocol without having to create a new protocol. So nowadays, the efficiencies of this design are quite widely recognised. There's quite a lot published on this. But there's actually surprisingly little published about the operational challenges of these kind of trials, or these kind of protocols. I will keep saying trials instead of protocols, but I mean protocols, because that's the terminology we're now using. So today's webinar, I'm going to be drawing from the experience we've had here at MRC CT at UCL, so primarily from the Stampede trial and the Focus 4 trial. I'm going to be focusing on the data management challenges specifically, and this follows on from the trial management focused webinar that Francesca did last week, which I think is now available to download, and I'll be giving you a link to that later. So just briefly to look at the two different trials, the two main trials that we've run that use this design. So Stampede is a multi-arm, multi-stage prostate cancer trial. It opened in 2005, and then it had 5 different comparisons. 5 additional comparisons have subsequently been opened, and a biomarker stratified comparison is currently being piloted, or has recently been piloted. So on this protocol, the control arm patients are shared on one control arm amongst contemporaneously recruiting comparisons, and we now have just reached the 10,000 patient mark with Stampede, so it's a big protocol. So Focus 4 is a slightly newer protocol. Again, it's multi-arm, multi-stage, this time in advanced or metastatic colorectal cancer. It uses biomarker stratification to allocate the patients for all of the comparisons. The trial opened in 2013, so at that point it had 1 biomarker stratified comparison, which was D, and 1 non-stratified comparison, which was N, and it has subsequently opened 2 more biomarker stratified comparisons, so B and C. And Focus Forward, or Focus Forward D, has now closed the recruitment, and there are more comparisons potentially in the pipeline, as you can see from this diagram. So in this protocol, it's slightly different. So each comparison includes its own control arm and research arm, so they don't share a control arm. So at the moment, in this protocol, we've got about 900 patients registered and about 240 randomized across all of the comparisons. So in terms of data management challenges for this design of trial, so myself, along with Stephen Townsend and Dominic Haig, who are also my data scientist colleagues here at the unit, we talked to a range of our other colleagues with experience on these kind of protocols, so statisticians, trial managers, data managers, programmers, and we discussed challenges that came out of these trials that we considered to be quite specific to the adaptive platform protocol design of the trial. And we found that these challenges could be broadly grouped into 5 key areas. So that's CRF design, development and maintenance, database design, training and documentation, data cleaning, and also resourcing for the various competing data management activities. First of all, we're just going to briefly look at CRF development. So the specific challenges that this kind of trial design gives in terms of CRF development is that the CRF need to remain flexible in the face of the changing data requirements when you're adding and removing comparisons. So obviously adding a comparison means that extra questions must be added to the CRF, which are comparison specific. And that might also include changes to the control arm if you're using a shared control arm. And there'll also be changes across, or there's also likely to be changes which apply across all comparisons, as there are often in all trials or protocol changes, but especially these trials tend to be quite long trials. So you're fairly likely to be getting changes in practice and things like that you'll have to incorporate across comparisons. So one strategy that you could use when you're developing CRF for this kind of trial design is having generic CRF across comparisons. So we're talking about, for example, if you've got a follow-up form, you'd have the same follow-up form across comparisons, but you might have specific comparison-specific questions or sections on those forms. So a couple of advantages to this way of doing things is you'll end up with fewer CRFs to have to manage. And if you have got these cross-comparison or protocol-wide changes, it will be quicker and easier to update CRF if you've got generic CRF. So disadvantages of this approach, so these CRFs, obviously when you're adding questions and sections, they will be increasing in length and complexity. And they'll have less flexibility when you're adding questions, and you'll end up with things like numbering issues. So you might want to add a particular question into a particular section for a new comparison, but you want to keep the same numbering to avoid confusion across different versions of CRF. So you actually have to add the new question at the end. It doesn't really follow in the logical sort of flow of that CRF. So you can have issues with things like that. So another approach would be to use comparison-specific CRF. So for example, you have a follow-up form, a separate follow-up form for every comparison in the protocol. So this can be useful if you've got quite varied data requirements across the different comparisons. And it's less complex when you're adding a comparison because you'll just be creating a new form, base it on the old form, but you're not having to sort of fitting all different questions. Or if you're updating, or for sites to complete as well, because they're likely to be less complex in terms of the flow of the CRF. And also likely to be shorter, which is, so sites aren't having to print out multiple bits of paper and send in to the CRF. Disadvantages for this approach is if you've got cross-comparison changes, then you have to make these across all of the CRFs. You'll have more CRFs in total, and it can be more complicated for sites in terms of remembering which CRF they're supposed to use for which patient and things like that, and you've got more opportunity for error in terms of choosing CRF to complete. So in terms of what we'd recommend for developing CRF for this kind of protocol is we wouldn't really recommend one of these over the other specifically, but it's important to consider each CRF carefully. So if you've got a CRF that you think is likely to change a lot over the different comparisons, then you might want to be using the comparison-specific CRF. But if you've got a CRF that is probably going to be fairly similar across the different comparisons, you might want to use a generic one CRF for that type of visit. So if you are using generic CRF, any generic CRF, one thing we would say is it's useful to use sectioning so that you've got a section that applies to a comparison, and then that might have its own numbering within that section, and then you can more easily put another section in with a different section identifier somewhere else on the CRF. And we found that is easier for updating generic CRF. Also going back to when you're developing the protocol, it's really useful in terms of when you're later developing CRFs and things to keep a similar visit schedule across the different comparisons. Also to collect data, as similar as possible data across in assessments across the different comparisons, and simplify requirements as much as possible. So now looking at database design. So the challenges in terms of database design are similar in terms of database development, with a few small differences. Mainly you're looking at, you need to come up with a system which will have flexibility and scalability as more comparisons are added and dropped from the protocol. So strategies for this, basically two main strategies. You could have a single database for all comparisons, or you could have multiple comparison-specific databases. So if you've got a single database, the advantage of this is that it's easier to make generic protocol-wide updates. Again, this is similar for using generic CRF, and they only need programming and then testing once. And another thing for databases specifically, if you've got all the data in one database, it's likely to be just in one set of tables, so that when you're creating reports to look at that data or extracting the data for analysis, you're not having to kind of sew that data back together from various different database tables. Disadvantages of this approach is that these kind of trials quite often you end up having a lot of patients on them. They're very long. They can be very long-running trials, protocols, and so the size of the database and database tables can get quite large, and this can affect performance. Obviously, this is very specific on the type of system you use, things like that, but this is something that we found. Also, when you're making changes to the database, you'll have to probably do a lot of regression testing to make sure that you're not damaging the sort of validity of the existing data in the database, so that has to be protected quite carefully. And as with the CRF, you might end up having complicated or confusing eCRF. So here's a quick diagram of this kind of approach, having a single database. So at the start, you've got a new comparison when the trial starts in blue, and then in the second box, you've got an additional comparison added in blue to the comparisons in follow-up, which are in orange, and then so on and so on. But as it says, you've got increasing time for developing and testing the old and new functionality every time you're making updates to the database. And you're increasing the size and complexity of the one single database. So thinking about the approach of having multiple comparison-specific databases, So you're more likely to have databases that are a manageable size with better performance. You're more likely to have simpler eCRF. It's easier to add a comparison. You can copy things from a different database, but you're not having to go back and test that you're protecting the old data. But the disadvantages of this, as I discussed before, are if you're working with the data, reporting or analysing the data, you're going to have to do some extra work probably to bring that data back together. And if you've got any generic updates which are across the whole protocol, then you're going to have to program those and do testing on all of those databases. It's obviously more time consuming. So the diagram of that approach, quite clear to, it's quite similar to the other diagram, but you've got the new comparisons are in blue, start the trial, and then when you're adding comparisons later on, they're all going into separate databases. As it says there, you're increasing the number of databases to develop and test, but then at the same time, the size and complexity of the database is protected in this approach. So I haven't really got any recommendations for databases. I haven't got a recommendation slide because it's really similar to what we talked about with CRF. You have to really think about the particular protocol that you're starting and think about how similar the comparisons are and all of the things that I've discussed, the pros and cons, and then make your choice from that. And there's always going to be some things you maybe don't know at the start, but it's really important to think a lot about it at the start so you can make the best decisions possible to kind of future-proof the system for the length of the protocol. So now going on to training and documentation. So the complexity of data management activities in these platform protocols is likely to be increased. You've got a lot of different things going on for different comparisons and things like that. On top of that, the trial is likely to be quite long, and that can mean that initial site training alone may not be adequate to cover the life of the trial. So when you're adding a comparison, it can mean extensive practical changes to the data collection requirements of the CRFs and systems, which means that there'll be additional training needed for central staff and site staff. And then you've got the central data management documentation, such as DMP, will also need reviewing and updating when you're opening and closing comparisons. So what we'd recommend and what we do on these kind of trials is to use a sort of main set of training slides or documents which includes all of the information that's applicable to all of the comparisons. And then we supplement this with comparison-specific documents. So this means it's fairly straightforward to add information to the new comparisons, but then if you've got generic updates, then they only need to be made once for the main document. And it's really important, I'll say this, it's not always something you maybe think about when you're starting the trial. It's really important to factor in that with the resource that is required for these training and documentation updates throughout the life of the protocol when you're adding and removing comparisons. So now to go on to data cleaning. So one challenge that we found can be making sure that you've got non-biased processing of all of the trial arms and comparisons. So this is really an issue if you've got a trial with or a protocol with a shared control arm like Stampede. So if you are coming up to say an analysis for a particular comparison and it's a big busy trial and you've got a lot of queries, it can be tempting to send out queries for that specific comparison, get those cleaned up, and then just do that for every comparison as the analyses are coming up, as well as the sort of general ongoing cleaning. Unfortunately, this means that if you do this, it means that sites have more of a chance to, or are prompted more to report events, resolve queries for the control arm. So you can see here, you've got 4 chases happening one after the other. On the first one, you're chasing information for comparison 1, which is the control arm and research arm 1, so on and so on, the different chases, but each one is chasing for information on the control arm. So you might there are more opportunities for sites to report these events and things, so the risk is that you're told about a higher proportion of events on the control arm than on the other arm. So it may induce bias in the analysis. And another aspect, which is kind of more across all large trials, is if you are just chasing data items that are considered kind of more important for specific analysis and things like that, even if you're doing it across all comparisons, you could well end up with the other data items being neglected, being lower quality, and obviously you want to make sure you've got data quality over all of your data. So in terms of our recommendations for data cleaning, if possible, we would recommend that you clean the data concurrently for all data items across all arms and comparisons. If you do need to split up things like query chases and things, we think it's best not to split by comparison or specific data items. So something we have tried doing is chasing for queries or forms to do with specific CRF types, but doing that in cycles. So over a few cycles, you're covering all of the different CRF types. So this obviously reduces query burden on sites compared to chasing all of the queries at the same time if you've got a large number of queries. But it does mean we found that it can be frustrating for sites having to retrieve the same patient file more often, and also if you've got some cross-form queries, they might not be resolved until all of the relevant cycles are complete. So it's not without complication, and we would recommend chasing for data, all the data at the same time. So there are options. Okay, so the final area I'm going to talk about is resourcing for all the competing data management activities on these kind of trials. So thinking about a more traditional trial, you'd have a phase at the start of the trial before the trial opens, and the data management activities there would be things like developing CRF, database development, preparing site training documents. And then you'll move on to the recruitment phase of the trial, and then you'll be managing incoming data, so data entry, resolving data queries, chasing missing CRFs and things like that. So thinking now about one of these platform protocols, you've got much more of an overlap with these tasks. So you're likely to have several comparisons at different stages in their life cycle. So again, you'll have the bit before the protocol trial opens, where you are preparing CRFs and creating database and things like that. But then once those comparisons are initially opened, you're then managing that data that's coming in, but at the same time, you'll be doing preparation for opening other comparisons. So those tasks will be overlapped, and you'll need a lot more resource. So the opening and closing of comparisons can be fairly resource intensive, and it can be quite time sensitive. And failing to plan for this and acquire adequate resource, you could risk the quality of data. You want to make sure you've got enough time to be creating, planning and developing CRF and database updates properly with enough thought, especially if they're more complicated later in their platform. And also, you need to make sure you're still doing sufficient cleaning and processing of the incoming data. So our recommendations for this would be definitely consider this at the funding stage. Our recommendation would be to consider what you'd resource data management-wise for so if you've got a comparison on this platform, what would you resource for a trial of that size in setup and follow that for each comparison, as far as you can. That's what you're aiming for, really, because not having enough resource can quickly cause a lot of problems, especially in these large trials. And then reviewing how much data management resource you need throughout the life of the protocol. So those are the main areas that we identified. We would like to do some further work as well, or it would be good to see this further work being done. So it'd be interesting to see what the data management challenges for these type of protocols are in the site setting. Are there things that we haven't thought about? It would be really useful to get some kind of metrics to develop metrics to formally compare the different approaches used, different kind of CRF and database and things like that. And also, it would be really useful to get some kind of tool or algorithm to work out how much resource we need for these types of trials. So in conclusion, these adaptive platform protocols do pose some novel data management challenges, and future-proofing is essential when designing CRFs and database and any processes and systems on the trial. The amount of data management resource required is almost definitely likely to be more than that for a single traditional trial. But then we consider these trials that we've run a success, and we encourage people to still use this trial design and reap the benefits of the efficiencies of this trial design, but take into account these things that we found, these considerations early on. And we have actually got a publication in progress. We've got two, so we've got one based on trial management side of things, and then one based on what I've talked about here, which is data management side of things. So I've got some acknowledgements here as well, and references. And then I've also added a bit here. So if you're interested in any further discussion on this, again, Francesca Schiavone did trial management a webinar a couple of weeks ago, and the recording is now available, and I've got the link there. And we are actually thinking about planning a focused workshop that's focused on the trial conduct side aspects of these platform master protocols, and we're hoping that that will be in London in autumn 2018, so stay tuned. And feel free to email me, so lmasters@ucl.ac.uk. Thank you very much.
Thank you very much. That was another really interesting session. For those of you who've been listening, this is your chance now to ask questions, and you can see from this slide how you can do that. You can enter your comments in the chat box, or you can put up your hand, and we'll marry those two things together and get to you gradually in turn. I should also say that Lindsey has a few colleagues with her today, so if there are any questions that become a little bit wider, she has appropriate people with her who will be able to speak to you too. They'll introduce themselves and answer your questions if it happens to touch on their particular areas. So if there are any questions, please could you start either putting your hands up or writing them in the Q&A or chat box, and we'll keep an eye out for those. In the meantime, maybe I could take the chance to ask the first question while everybody's thinking and gathering their thoughts. Lindsey, obviously you're dealing with very complicated situations when you're adding all of these multiple comparisons through the life of the platform protocol. And when you're doing that, what sort of strategies do you have in place to make sure that all of the data that your protocol says it needs are captured for the right patients?
Okay, so this is an issue every time well, at the start of the trial, when you're creating CRF, making sure that you're collecting all the data that you need in the protocol, and then also anytime you're doing any kind of protocol update. But it can become more complicated on these kind of trials or these kind of protocols, because you're doing so many sort of large updates to the protocol throughout the life of the trial protocol. So we always make sure that we have a process every time there's a protocol update. So we will review any of the data items that are added or changes in data items that need to be collected in the protocol, and we have a process where we map that through to what changes that will require for the CRF, or what changes that will require for the database. So it might be things like validations that need adding and things like that, to make sure that we always capture all of those changes in the protocol. And it can be quite a sort of challenge to do that. And also you have to think about whether, when data is added, is it just being collected on the new research arm? Does it need to be added to a common control arm? Are we making a change that needs to go across all comparisons? Things like that. So it does need a lot of thinking about.
Yes, I'm sure it does. Thank you. We've got a couple of questions coming for you. I don't know whether you can see them, Lindsay, or whether only I can see them. I'll read them out for everyone's benefit. We have one from Fernando da Silva. How do you engage successfully with stats teams to deliver the analysis to ensure that the new comparisons are being built and based on previous comparisons time efficiently? That's quite a complicated question for you. Do you want me to, can you see it, or do you want me to read it again?
How do you engage successfully with stats teams to deliver the analysis to ensure that the new comparisons have been built are based on previous comparisons time efficiently? Yeah. So I'm not 100% sure I understand. Could you perhaps give a little more information on what you mean?
What we can do is move to the next question and then hope that the questioner can sort of clarify a little bit. Would that help?
Yeah, that'd be great. Thank you.
Thank you. I'm just trying to see. There's another question. I'm not sure where it's gone. People put them in different places. Oh, great. So Danielle Johnson had a question. Let me see. If you were starting a new trial, like Focus 4 or Stampede, how would you favour setting up data? How would you favour setting up databases and CRFs?
Yeah, that's a really good question. It'd be really good to have sort of a perfect answer where we say, do it this way. So much of what has been challenging in these trials was unknown when they started, unfortunately. But then again, so much depends on the specifics of the proposed comparisons within a platform. So the main thing I say is make sure you've got enough time or make enough time to think about all of this stuff early on. So in terms of the pros and cons of different things that we've talked about, and we've got some recommendations in some areas, but it's thinking about this protocol might well be going on for a long time. And it really does take to put time at the start into thinking through all of these areas in terms of, so that goes all the way through. So CRF, is the data going to be very different across the comparisons? So you might want to split up your CRF. If it's going to be quite similar for a specific CRF, you might want to use one CRF for all comparisons. But you don't have to just pick that one strategy for all your CRF. So thinking about each one. Basically, you'll still have challenges that come up because you can't really predict everything, but if there are things you can plan for from the start, it will put you in a better place, really, to address the challenges when they do come up later. And again, resource is key here as well, because if you're needing to sort out any issues that might come up later, then you're going to need a resource to do it.
Yes, yeah, I can see that. I can definitely see that. Thank you. We have a question from Andy Metcalf, who apologises in case you missed you covering this at the start, but says that he's interested in how you managed your oversight committees. Presumably they had to be adaptable to cope with changes and additions and removals.
Yeah. So this is a bit more of a sort of trial management side of things. So I'm going to pass this over to Francesca, who did the webinar last week about trial management.
This is something we touched on very, very briefly last week or a couple of weeks ago, and it's something that we want to expand a little bit more in the paper that we are about to submit. So the first thing is, in terms of trial oversight committees, they have to be very collaborative, and starting with the TMG. So the structure, the trial management group, the structure that we had is that we have in Stampede one CI, one chief investigator, but each new comparison is led scientifically and clinically by an expert in the area, so a co-chief investigator or lead investigator. The terminology might change a little bit between Stampede and Focus 4, but the principle is the same. We were very lucky in Stampede for a number of years, particularly for the until the completion of the original comparisons, because we had the same independent data monitoring committee and trial steering committee group. But obviously these trials are sort of last for a very long time. Stampede started in 2005, so thinking about the longevity of the oversight committees is quite important. Naturally, Some people step down for a number of reasons, typically just retirement from IDMCs and TSCs. And what's important is to identify those colleagues that can join the IDMCs and the TSCs, but have a sufficient understanding and knowledge of the design, because obviously they're faced with quite difficult decisions to make at times. So we have an initial introductory training program for new IDMC members and TSC members, where we present not just the background of the trial, which in itself could be quite easily explained through the protocol, but also presenting a number of scenarios of what could happen at each interim analysis and what the implications will be. And it's absolutely vital, not just that the IDMC obviously understands it, and there's always a statistical sort of representations within the IDMC, but the trial steering committee, because effectively that is the executive committee of all oversight groups, and they will be faced with having the recommendations with the IDMC and deciding effectively whether an arm could continue or stop. So understanding the implications that come and the complications and challenges that come with MUM's design, adapted trial designs, is quite important. But we've been very lucky so far. Not sure, it's a very long answer. I'm not sure if I addressed the question.
No, thank you. That seems great. And we can go back to the previous question. Sorry, thank you, Francesca. We can go back to the previous question now, because we have a bit of a clarification about. Oh, I am very sorry, my phone is ringing. Rihanna, could you mute me for a moment, please? Thank you, Rihanna.
I mean, I can answer. I've seen another question come up there about how do we handle database lock if we've got different databases. So if we have a database lock procedure that we use for a particular database. So we tend to see that on quite a database specific level. So if we've got all of the data for that comparison and all of the patients within that comparison, and we've cleaned it and everything, then we would go ahead and lock that database, form database lock, remove rights and things like that, and analyze that data, and then we can still carry on with the other databases we've got, recruiting and adding data and things. And obviously, if we've already got it on all one database, then we'd have to wait to do database lock at the end of the whole protocol, which could be a long time. But we have got, I mean, so we've also got a procedure that we use when we're analysing data for a specific comparison, when we can't do a full lock, a sort of final lock of the database. If we've got all of the different comparisons in one database, we've got a procedure that we use so that we make sure we clean the data for that comparison, and then we've got a locked kind of copy of that database at that point in time, which means that we can have that in case anyone wants to go back and, you know, make sure that was all okay. And then the statistician can analyse that, and we can present results on that and still continue with the live database, collecting data and things like that.
Thank you. I don't know whether you can hear me. Can I just check? It's Claire.
Yeah, we can hear you.
Lovely, thank you. So we have a question. Thank you for dealing with that while I had to mute. We have a question from Chris Rogers, who's the other chair of the working group. So hello, Chris. She says, if you were starting a new trial with similar modifications anticipated over its life cycle, what would you do differently? How have your users responded to the choices you've made in Stampede, CRFs and database? So two questions in there, really. What would you do differently, and how have people reacted to the choices you've made?
Yeah, so there are various things we do differently. For example, I would say in Stampede, we chose to have all of the patients on all the different comparisons entered into one macro database. initially, and that caused us a lot of problems in terms of how big those database tables got and the performance of that database. So we have now split that up by site, but we would have initially done that a bit more cleverly in the first place. In terms of CRFs, I think Stampede, because it was so long ago, we started off with quite generic CRFs across the different, so getting all the different comparisons, all the different arms and things in one set of CRFs. And over time, they became very complicated. And I think now, actually, we've started to have, for some particular CRFs, we've redesigned them so that they're comparison or arm specific. We're trying to simplify things a bit more. So I think for Stampede especially, there are things, we would have made things a bit more comparison specific in terms of CRF and database, really. In terms of, I mean, there are things that, both things that we've addressed and managed to make some changes now. It's just much harder if you do it later on in the trial. In terms of resourcing, we would have definitely got in more resource early on. We've got, how many data managers now have we got on that trial? 7 data managers now on that trial. I don't think at the start of the trial anyone would have thought we'd need that many, but we do, and they're very busy, those 7 data managers, as well as I think 5 or 6 trial managers as well. So definitely resource is a thing that we would have thought a lot more about at the start, and we try to do these things better on Focus 4, and we tried, like I've been talking about, we tried to think about each CRF and each CRF, whether we need to do that generically or specifically across comparisons, think more about how we did the database. In terms of trial management, think more about how we've got a sort of main protocol, but then little protocols that sit alongside that, so that's easier to use. So I think the way we've done things in Focus 4 has shown how we would have liked to do them in Stampede at the start, really. In terms of users, I'm not sure whether that means kind of sites or here. In terms of sites, I think when CRFs get too complicated, we've had some feedback that it would be better if things were split up and things like that we've responded to. There's another thing. Sites are really keen to have a lot of training, basically. I think initially it was hard to sort of understand how much training would be needed, but every time you add a new comparison, it's basically like, in a way, like starting a new trial. I think sites have responded well to us doing thorough training with them and discussing with them in what way we can best deliver that when we've added new comparisons and things for Stampede and for Focus 4.
Great, thank you. Unless you covered that stats question while I had to quickly mute, I think it's time to go back to that. Did you cover it?
So the way I'm interpreting it, in terms of the stats team delivering the analysis, we try to make sure that as far as possible, we ask questions in the same way. So we're asking the same question across the different comparisons, and things like variable names we try and keep the same. So we try and think about that as early as possible, and trying to get input from the statistician to look at how we set things up, and also look at things like validations and things like that across comparisons as early as possible, and also having their input into the database setup, the database tables, and how easily it will be for them to look across that data and report it. And I think that Fran has got something that she wanted to say.
I might have misinterpreted what sort of the question is trying to get at, but I think
we did have a clarification. Just yeah, to your work.
Yeah, sorry, I think I'm being a bit slow. I don't understand the clarification either. But I have an example. So in Stampede, the planning of analysis, and particularly the interim analysis, has a lot of sort of accumulating knowledge for a statistician. So for instance, the abiraterone comparisons, which was the first one to be added in 2011, recruited quite quickly, a lot faster than we envisaged to start with. And typically, all the comparisons from that point onwards had 3 interim, pre-planned interim analysis, activity analysis. But when we introduced the abiraterone and enzalutamide comparisons, which came about 3.5 years later, we were obviously strong of the knowledge that we accumulated for the abiraterone comparisons. We're conscious of the fact that recruitment was projected to be a lot faster than initially envisaged, and therefore the statistician planned the interim analysis in a slightly different way. And in fact, we had only 2 interim activity analysis for the abiraterone and enzalutamide comparisons, because obviously what we didn't want to find ourselves in was to sort of recruit too fast and effectively have an interim analysis when recruitment was already completed, because obviously that brings a lot of other sort of safety questions, I guess, that you know, one wants to consider. So the knowledge of how previous comparisons that act very similarly has been very useful in planning future comparisons. But I probably have misunderstood entirely what the question was about.
Well, okay, thank you. I hope it does address the question that was posed. I think it probably does. Thanks, Francesca. We have another question from Joanne Copeland, who says, do you think moving to RDE at sites could help with some of the DM challenges of platform protocols?
So Focus 4 is actually RDE. So it's what we call EDC. So for most of their CRF, they actually don't use paper CRF. They use eCRF, so they enter straight from source data into the database. And there are only sort of 2 or 3 forms where they still complete them on paper for various sort of technical reasons. And I would say it doesn't really address the issues that come up. You've still got from the data management side of things, you've still got the issue with how you're going to split up the CRF, but it would just be more the eCRF. It means that you don't have, if you've got database, the database can do conditional opening of questions, so you don't have to have the go to question this or that, because it'll close off those questions. But it can still be quite confusing on looking at a screen that has half the things closed off and half not, and several pages of forms. Also, we have found on Focus 4, across the different kind of EDC trials we have, they seem to work better for us with fewer problems on trials that have less complicated visit schedule and are generally less complicated. Focus 4, I think, sites using the database, we had to do a lot of training on all of the different forms across all of the different comparisons, and they still, I think, had some issues with kind of making sure they pick the right form in the database and things like that. And I mean, we tried to make the database as straightforward as possible. I guess you would have, well, not particularly for this kind of trial design, but you would have less data entry to do here at the unit here, for if it was an EDC trial. But again, we find that it doesn't really reduce the amount of data management resource you need, because you need to do a lot more checking of the data, making sure that they've entered it without issues, and responding to queries and things like that. So you still need quite a fair bit of time put into that, and you still need a fair bit of time for developing database updates and things like that, and a lot of training. So we haven't really found that for sort of Focus 4 versus Stampede, really.
Okay, thank you. That was actually the last of our questions, Lindsey. So is there anything that you or your colleagues that are with you would like to add to what's been said so far?
No, I don't think so, apart from just if you've got any more, if you do come up with any more questions, then please contact us, contact me, and I can, if I'm not the right person, I can pass them on to someone else. And we will be circulating more information about, hopefully, the workshop we'll be doing. And yeah, just to go and listen to Fran's webinar from last time if you haven't yet.
Yes, thank you. I think the two will be nice to listen to back actually when they're both available, and we can certainly connect the two on our website. So thank you very much, Lindsey, and thank you also, Francesca, who's listening too, for your input to this sort of grouped presentation. It was been really a very useful focus on these adaptive designs. Our next presentation is going to be by Chris Rogers, who gave a question earlier, and that will be at the end of May on the 29th. So if you're interested in that, that would be great if you came along. Chris is going to be talking to us about audio recording recruitment consultations. Her title is an exploratory study in 2 RCTs to investigate the impact on randomization rates. So that's 29th of May, and you're very welcome to all come along. Thank you very much for joining. I hope it's been very useful. Thank you. Goodbye.